Hello friends, in the sequence of ENT lectures, we are going to discuss a very important and a short topic today, which is a kind of a tumor, but it's not a malignant tumor. We are discussing about a tumor which is related to a young age population or a early adolescent population. It is benign in nature and uh, it is a tendency to have a severe epistaxis. So today's topic will be juvenile nasopharyngeal angiofibroma, or also called as JNA. So uh, now onwards, or in this class, this juvenile nasopharyngeal angiofibroma, we will shortly call it as a JNA. So let me take a pen first. Okay, this juvenile nasopharyngeal angiofibroma or JNA is a benign expensile 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 in the sense is it has a tendency to expand, and it usually in cases of a malignant tumors, they have a property of invasion of surrounding tissue or destroy the surrounding tissue. But this benign tumor has a tendency not to invade the surrounding tissue, but it you can say that it shifts or presses, or you can say it expands in the form that it tends to uh, effacement in the sense it shifts the surrounding tissue to the periphery, and the invasive property as seen in malignant tumors are not observed in this JNA. So it's a unique tumor. It's a unique benign tumor which is extensively, or you can say exclusively seen in juvenile patients or early adolescence patient. It's the age of the JNA. The lower age is 8 years and the upper age is about 15 to 16 years. But older population has also got reported in the literature, but this is the peak age group of having a JNA. So JNA by definition is exclusively seen in male population because it has got these receptors for androgens only. The tumor, the surface of the tumor, as well as the matrix of the tumor has got receptors for androgens, not for estrogens and progesterone. So the tumor is exclusively seen in male population and mid early adolescence or late childhood population. Apart from that, this is a very that this unique tumor is almost never seen in female population. So we will skip the history now. So in order to know what kind of a tumor it is and what kind of a extension this JNA has got, you have to study the infratemporal fossa and the sphenopalatine fossa, because the tumor arises most commonly in the nasal cavity or in the nasopharynx, but invariably it will lead to invagination in the sense is entry into the through the sphenopalatine foramen into the sphenopalatine fossa and then into the infratemporal fossa. So by and large, the anatomy stands like this. So this is the entry of the nasal cavity side. This is supposed to be the nasal cavity. So this spine, this sphenopalatine fossa is like a cone or like a pyramid, and the lateral wall is found by the extension into infratemporal fossa, whereas the medial aspect of this sphenopalatine fossa is continued through the sphenopalatine foramen into the nasal cavity. So it's a cone shape structure, and the important you can say boundaries of this sphenopalatine fossa is it has got superior wall as the orbital cavity or infraorbital foramen infraorbital foramen infraorbital no, not infraorbital foramen, this is infraorbital fissure. The lateral wall obviously will be the extension into the infratemporal fossa. The anterior wall of the sphenopalatine fossa will be the posterior wall of the maxillary sinus, and the posterior wall of the sphenopalatine fossa will be the lateral pterygoid plate. Lateral pterygoid plate. Medially, this fossa is extended into the sphenopalatine foramen, and which enters into the nasal cavity. So these important landmarks are very important in order to know what kind of extension and expansive property this JNA is having. So this is a typical tumor or a unique tumor which is particularly present in or exclusively present in adolescent male population, and it forms about 0.5% of or a half percent of all head and neck tumors, and in female population this is not seen. And where the tumor is, or what exactly is the tumor location, it is the nasal cavity, the nasopharynx. It can also encroach or invade through the foramen lacerum. It can even foramen lacerum. It can even enters into the middle cranial fossa. The content of the foramen lacerum are internal carotid artery, the GSPN or greater superficial petrosal nerve, and the ascending palatine artery. So the content of this sphenopalatine fossa, as we have already discussed, it extends laterally into the infratemporal fossa, and medially it is extended through a narrow opening which is called as sphenopalatine foramen into the nasal cavity. And this sphenopalatine foramen has got a sphenopalatine artery. And the sphenopalatine fossa has got primarily two components. Number one is CNV2. What is CNV2? CNV2 is the second division of the fifth cranial nerve, that is trigeminal. That the second division is called as a maxillary division. So sphenopalatine fossa has got maxillary nerve CNV2. The second division of the trigeminal nerve is called as maxillary nerve. So in the cranial fossa, after having its emergence, this trigeminal nerve second division enters into this sphenopalatine fossa through foramen rotundum. So let me give you a picture of this. Let me take you to this. After coming out from the cranial cavity, this V1 or first division of the trigeminal nerve, or first division of V1 is first division of the trigeminal nerve, that is ophthalmic nerve. It enters into the orbital cavity through superior orbital fissure. And the second division is called as mandibular nerve or V2. mandibular nerve to V2, it enters into the sphenopalatine fossa through foramen rotundum, which is present just inferior to the sphenoid sinus. And the third division of the trigeminal nerve, that is V3, it enters through the for it enters into the to the head and neck. It leaves the cranial cavity through foramen ovale foramen ovale, and this is called as mandibular. This is called as sorry. This is called as maxillary nerve. Correction. The V2 is called as maxillary nerve, and V3 is called as mandibular. And this mandibular nerve again has got two prominent branches, two prominent nerves. It has got number one is inferior alveolar nerve, and number two is lingual nerve. These are two primary divisions of the mandibular nerve. Maxillary nerve has got various divisions like nasociliary nerve, the zygomatic nerve, and palatine nerve, greater palatine nerve, and lesser palatine nerves, and superior alveolar nerve. So whole of the face, the mandibular region is supplied by this V1, V2, and V3. So we are talking about the contents of the sphenopalatine fossa. We are talking about the contents of sphenopalatine fossa. It will be number one will be V2, number two will be number two will be the maxillary artery itself. Maxillary artery. So we have got this maxillary artery is a division of external carotid artery. External carotid artery. External carotid artery. So this maxillary artery is a division of uh, external carotid artery, and it is continued through this sphenopalatine foramen and enters into the nasal cavity, and it is named then as the sphenopalatine artery, which is a major supply of the lateral wall of the nasal cavity. Lateral wall of the nasal. The third one is pterygopalatine ganglion. Pterygopalatine ganglion, which is again a parasympathetic ganglion. Parasympathetic ganglion. The post ganglionic fibers supplies to the lacrimal gland, and the mucus secreting glands of the oral cavity and the nasal cavity. So the pterygopalatine ganglion, the maxillary artery, and this V2 or maxillary nerve. These are the major contents of the pterygopalatine fossa. We are discussing this in detail, this pterygopalatine fossa, because invariably the extension of this JNE is happens to be into the pterygopalatine fossa, which is present just behind the maxillary sinus. If you consider this maxillary bone, it has got a cavity which is called the maxillary sinus. So this pterygopalatine ganglion is located behind this maxillary sinus and in front of lateral pterygoid plate of the sphenoid bone, and laterally it is extended into the infratemporal fossa, and medially it is extended into the nasal cavity through sphenopalatine foramen. So these are some fine points. So let me take you to the various theories are proposed as far as JNA is concerned. JNA is concerned. Why this is supposed to be a pathology which is limited to this young adolescent population or late adulthood population? Because there are various theories are there, or like Rinker's theory, but majority of the theories nowadays are having a consensus on the fact that it arises from some embryonic cells which has got androgens androgen receptors on it. And in the young adolescents, when the circulation of these androgens are enhanced, then the tumor start expanding, and it is a highly vascular tumor. Let me show you that the tumor the tumor has got two components. This JNA has got two components. The first one is vascular component, and the second one is fibrous component. So it's a fibrovascular tumor, benign tumor. It doesn't uh, erodes the bone or destroys the bone or invade the bone, but rather than it compresses the bone, it pushes the bone. It is expansile in nature, but the like a carcinomatous growth, it doesn't uh, it takes an entry or invade into a vascular structure or a neurovascular bundle or an important vital structure. It pushes it to the periphery, but the chances of invasion in a GNA are very limited in every sense. The vascular tissue and the fibrous tissue. This vascular tissue is formed by vessels, and the blood supplies comes both from the majority comes from the external carotid artery. So this external carotid artery has got 7 branches, and the maxillary division, like the 7 branches, like this superior thyroid artery, facial artery, maxillary artery, and apart from that we have got superficial temporal artery. So 7 branches. Maxillary artery is the major vascular component of this tumor. Major vascular component is arising from the maxillary artery, which is a division of external carotid artery. So it has got the tumor has got tendency to bleed heavily, because also the wall of the blood vessels which are present into the tumor itself are devoid of muscle. So we have got 3 layers in a artery: tunica intima, tunica media, and tunica externa. The tunica media is supposed to be a muscular layer. So the presence of this muscular layer causes a vasoconstriction phenomena, which helps in primary or secondary hemostasis, primary hemostasis. So, but there is an absolute absence of this muscular layer or tunica media, and hence the chances or the tendency or propensity of bleeding in this JNA are far more than a common bleeder. Apart from that, the fibrous component is like a collagen component. And in periphery, we have in the periphery of the tumor, we have got much of a fibrous tissue, and the core of the tumor has got a rich vascularity, or the major bleeder vessels or major vessels are present in the core of the, or when you go towards the center of the tumor, then the vascularity increases. So the theories also says that there are this vaso endothelial growth factor is also found in enhanced quantity, or this specific vasoactive amine is found extensively in the tumor itself. So this is supposed to be this VEGF is related to increased vascularity, and this JNA again has got this receptors for androgens. So the same age group, when the physical growth of the patient increases, or the adolescence increases, the tumor also expands in size. At most of the cases, it arises from the roof of the nasal cavity, from the nasopharynx, and even posterior part of the nasal cavity. Then it go anteriorly or posteriorly or laterally in the senses to fill the sphenopalatine foramen, and then the pterygopalatine fossa, and even extends even to the to the infratemporal fossa, and through various foramen and fissures, the tumor may extend intracranially, and the chances of having recurrence or a failed surgery are much more enhanced in these cases, especially if there is extension of the tumor into the intracranial space. Intracranial space. So, site of the origin, most of the former ENT literature was about the tumor getting its origin from the skull base, like a pharyngobasilar fascia or buccopharyngeal fascia. So the skull base was supposed to be the originating site of the tumor, but later on the tumor has got a. It was confirmed that tumor. Uh, Majority of the tumor has got its attachment or its origin from the posterior part of the nasal cavity, and even into the even from the nasopharynx. So this is a macroscopic picture of this GNA. So it's a nodular rubbery kind of a tumor which has got two primary components, a vascular component and a fibrous component. In periphery, the fibrous component is there, and in core, we have got much of a vascular tissue. The blood vessels are large, irregular blood vessels are which are arranged in a sheets. So the chances of bleeding in this JNA are extensive, and even the biopsy is contraindicated because the chances of this the bleeding from a JNA are quite augmented. In most of the cases in surgical practice also, they have to be supplemented with a blood transfusion during the operative procedure or even before the operative procedure. So this tumor, this GNA is a round, spongy and a nodular tumor which is non-capsulated tumor. The superficial layer or the outer layer is just an extension of the mucosa of the nasopharynx, which is squamous epithelium. So the covering is non-capsulated and is found by the squamous epithelium of the nasopharynx, and it is absolutely pinkish in color in some cases, whereas the color may vary from even whitish or even grayish, grayish. So, so what about the histopathology? So you can see that there is a vascular tissue and a stromal component, which is a fibrous component. So the body is formed by the fibrous tissue, and there will be interspersed blood vessels also, and there will be large blood vessels. So you should not underestimate a JNA, because the chances of a severe bleeding or severe epistaxis are are quite common. So this the covering will be found by the pseudostratified ciliated columnar epithelium, and also by the squamous epithelium. The squamous epithelium and the matrix is found by the collagen fibers, and the stromal component is formed by the collagen fibers, and in center of the tumor or even periphery of the tumor, we have got large blood vessels or the fibrous component. So what are the feeding vessels, which this is called as feeding vessels? Feeding vessels are the which are the major blood vessels which are supplying the tumor, because in case of an extensive JNA, you have to ligate or embolize the feeding blood vessels. So majority of the JNA has got their supplementation or their source as a maxillary artery, which is a division of external carotid artery. But in case of an intracranial extension, the source may be an internal carotid artery, especially also in a case of a nasopharyngeal uh, tumor location, because in nasopharynx, the posterior wall of the nasopharynx, we have got fossa of Rosenmuller, fossa of Rosenmuller, and deep to the fossa of Rosenmuller, we have got internal carotid artery. So the source of this tumor may arise, majority of the cases will be from the maxillary artery, which is a division of external carotid artery. And this maxillary artery also is a component of sphenopalatine, is is continued as actually sphenopalatine artery, which again forms the this anterior epistaxis location, which is called as Kiesel-Beck's plexus. So the source of the tumor blood supply comes both from the internal carotid system and the external carotid system. So the the chances of expansion, or the tumor has got a tendency to expand. So what are the location of the expansion? It fills the nasal cavity first. The patient can have a unilateral or bilateral obstruction. If it fills the nasopharynx, then obviously there will be bilateral nasal obstruction. It fills the nasal cavity, and the patient will be presented with two important complaints. Two complaints, very important complaints. Number one is obstruction of the nasal cavity. Obstruction of the nasal cavity. And the second complaint will be unprovoked epistaxis. Unprovoked epistaxis. And epistaxis can be, in cases of JNA, can be a severe epistaxis. So it's a unique tumor. And so in every patient, adolescent patient or young adolescent or a child or late childhood patient which has got a epistaxis and a nasal obstruction should always be suspected for a JNA. So if then it fills the nasopharynx, it even blocks the eustachian tube, and the patient can have a secretory otitis media or increased chances of acute otitis media because of the collection of fluid in the middle ear as a result of obstruction of the eustachian tube and negative pressure in the middle ear. So even if it grows in size in nasopharynx, then it pushes the soft palate downwards, and even in some cases you can see the JNA hanging into the oropharynx. Through the nasopharynx, it extends in the oropharynx, and you can even look the JNA through the oral cavity through oropharynx. So it even extends laterally or behind the maxillary sinus, the behind the maxillary sinus. So this is supposed to maxillary sinus in the nasal cavity. So it is present in behind the extended behind the maxillary sinus to fill the pterygopalatine fossa. We have already discussed pterygopalatine fossa. It also invades then the all of the paranasal sinuses, including maxillary, ethmoidal, sphenoid, and frontal sinus. Not frontal is relatively not invaded because it is present in the frontal bone, which is way superior to the tumor extension. So maxillary, ethmoid, and sphenoid are invaded, but frontal will be spared. The middle cranial fossa and the anterior cranial fossa can also be encroached or invaded by various fissures, particularly by foramen lacerum. Foramen lacerum. Foramen lacerum, when the internal carotid, through which the internal carotid artery enters into the to the to the petrous carotid, becomes a petrous carotid, or becomes intracranial. So this foramen lacerum is present, you can say, just superior edge of the fossa of Rosenmiller of the nasopharynx, through which it takes an entry into the cranial, into the vault. The clinical picture I have already told that will be the nasal obstruction and unprovoked epistaxis, and also because the nasal cavity is obstructed, the JNA is filling the nasal cavity, the patient can have a reduced sense of smell, which is called a hyposmia, or total presence, or you can say absence of smell, that is called anosmia. Because of recurrent epistaxis, the patient may have a may becomes anemic as well, and blockage of the eustachian tube may causes this secretory otitis media or even otalgia. So we will discuss about the radio diagnosis in the form of CT scan or MRI, or even a arteriogram is very frequently done in order to actually locate what are the fetal vessels for the tumor are, as well as the surgical component in the next class. Please subscribe to my YouTube channel also. Thank you very much.